so we're going to deal with the causes of microcytic anemia. And this includes iron deficiency in all age groups. Iron deficiency is the #1 cause of microcytic anemia. It's also the commonest cause of anemia in the world. Thalassemia is #2. Then you have anemia of chronic disease, but this could be normocytic as well. Anemia of chronic disease could be both microcytic and could be normocytic. Lead poisoning, in which you see basophilic stippling. B6 deficiency because the cofactor of delta ALA in heme synthesis. Sideroblastic anemia, in which iron is deposited in the mitochondria, causing the appearance of iron rings called sideroblasts. So these are the causes of microcytic anemia. So in children, the cause of iron deficiency anemia is delayed weaning, in which the baby is not given any food other than the mother's milk for more than 6 months. It is recommended to give weaning foods containing iron supplements from the age of 4 months of age to avoid iron deficiency anemia in these small children. So delayed weaning is a cause, prolonged excessive breastfeeding. Even the use of cow's milk before the age of 12 months is considered to be a risk factor. Prolonged consumption of cow's milk to beyond large quantities of cow's milk till the age of 2 years is also a risk factor. There is prematurity, which is a very important factor because there's anemia of prematurity, which is an entity altogether, which happens in premature children. And some of these babies need blood transfusion when they're born. Other causes include hookworm infestation, which happens mostly in tropical areas, third world countries. Celiac disease is important. It's a cause of malabsorption from the upper duodenum, causing iron deficiency. Peptic ulcer disease is also a cause, and patients would usually present with symptoms of either duodenal ulcer or a gastric ulcer. Duodenal ulcer, the patient would be having symptoms of excess hunger and pain that is relieved on eating food, while gastric ulcers, the patient would have a decreased desire to eat food because as soon as he eats, the stomach would start burning. That's gastric ulcer. It's in the older age group compared to duodenal ulcers. In elderly patients, this could actually be one of the questions asked, like what is the commonest cause of iron deficiency anemia in an older person? But in an older person, though we should look for cancer, it's not the #1 cause of iron deficiency anemia. Nutritional deficiency is still the commonest cause because elderly people have a poor consumption of iron. And then we have colon cancer. So what we do is a stool for occult blood, and this needs to be done in 3 samples because sometimes 1 and 2 samples need not show anything at all. In some countries, they prefer to go straight for the colonoscopy, saying the stool occult blood testing is not valid anymore. Colonoscopy is definitely indicated, especially in older people. Gastroscopy and biopsy if we're suspecting a peptic ulcer, or even if we're suspecting a disease like celiac sprue. If there is an obvious menorrhagia, an ultrasound of the uterus is necessary, which could show us, it could either show us a fibroid or it could show us adenomyosis, important causes of extra bleeding. But sometimes it doesn't show anything at all, in which case we might need to do an endometrial biopsy to see if there is a cause like dysfunctional uterine bleeding. If there is no cause found and there is no obvious bleeding at all, we might even need to do a capsule endoscopy in order to see if there is any occult bleeding somewhere in the gut. We look for other diagnoses. If there's not clear-cut iron deficiency due to a bleed, then we have to look for other causes like thalassemia. In thalassemia, usually the MCV is quite low, it's to the tune of around 60. Thalassemia is checked for by hemoglobin electrophoresis. You do serum lead levels, especially in children, and you can do a peripheral smear examination, which you can see sideroblasts. The treatment consists of identifying the underlying cause and treating it. If we don't treat it, it will not respond to treatment. So we need to deworm the patient if it's indicated, especially in children. If they're playing with mud, it's better to get them dewormed once in 6 months. Dietary iron needs to be increased. If the patient is a vegan and not taking enough of iron, he needs to take iron fortified foods. Red meat has a good amount of iron in it. Liver is very good in iron. Green leafy vegetables like spinach, drumsticks and drumstick leaves are a very good source of iron. Dates and figs are also a good source of iron. Iron supplementation can be given orally or parenterally. Parenterally has its own dangers associated. If you give iron dextrose IV to a patient, there is a 0.7% risk of an anaphylactic reaction. Blood transfusions are indicated if the hemoglobin is less than 7 grams percent, or if the patient is in cardiac failure. It is also indicated in patients with heart disease who have a hemoglobin of less than 10 grams percent. In other cases, we wait and we provide oral or IV supplementation with iron or B12 depending on whatever is necessary. Oral iron therapy, we give either ferrous sulfate or we give ferrous fumarate at 325 milligrams in 3 split doses over the day. Each dose has 60 milligrams of elemental iron. Oral iron is best absorbed before food. However, people cannot tolerate it most of the time, so we tell them to take it with food. But ideally, it should be taken before food. And milk and calcium supplements interfere with the oral iron absorption, and that's one of the main reasons why people they are not told, not to take it along with food and milk and irons or calcium supplements, and they take them all together, and they end up not absorbing the iron. So that needs to be said. Then we need to continue the oral iron supplementation for at least 6 months after the correction of the iron anemia. This is in order to build iron stores inside the body. Coming to IV iron therapy, if the patient is intolerant to oral iron, then we need to give them IV iron therapy. In CKD and conditions with poor oral absorption, like in celiac sprue, we need to give them IV iron therapy. In pregnancy, when the patient is near the delivery date and we don't want to transfuse, and we know it's clear-cut iron deficiency, we can give them IV iron. You can give iron dextran, you can give iron sucrose. The newer one is iron sucrose. Iron dextran can be given at a dose of, calculate the kilograms in body weight, multiplied by 2.3, multiplied by 15 minus the patient's hemoglobin, and add another 500 milligrams to it for good storage. IV sucrose therapy, iron sucrose therapy in chronic kidney disease. In hemodialysis patients, we give it 100 milligrams IV twice a week after the dialysis session. And we continue on till we achieve a maximum dose of 1,000 milligrams. In non-hemodialysis chronic kidney disease patients, you give 200 milligrams per dose and 5 doses split over 14 days to a total dose of 1,000 milligrams. And in peritoneal dialysis patients, you give 300 milligrams, 2 doses, 14 days apart. And then we give 400 milligrams as an infusion 14 days later, a total of 1,000 milligrams. How do we prevent iron deficiency anemia in children? We give iron and multivitamin supplements to very premature and low birth weight infants. We introduce iron-containing food early at 4 to 5 months. We avoid cow's milk in the first 12 months. We avoid excess cow's milk up to 24 months, and we use fortified formulas and cereals. A bit about macrocytic anemia. Macrocytic anemia means the cells are large, red cells are large, and typically when you see the blood film, they are homogeneously hemoglobinized. That means you see them, they are rich in color, unlike in the hypochromic variety of iron deficiency. You see the full cell is full of hemoglobin. If the MCV is more than 110, it's typical of megaloblastic anemia. Most likely it is megaloblastic anemia. So in macrocytic anemia itself, you can divide it between megaloblastic and non-megaloblastic anemia. Megaloblastic is either folic acid deficiency or B12 deficiency. Non-megaloblastic anemia could be due to hemolysis, chronic liver disease, hypothyroidism, and even aplastic anemia. We'll just classify megaloblastic anemias. And so we're looking at the folic acid and B12 deficiency. There are certain other very, very rare causes like congenital causes and purine antagonists, pyrimidine antagonists. We won't deal with that. but B12 and folic acid deficiency is very important. B12 deficiency can be because of a poor dietary intake. Now, it's not just in vegetarians that you get B12 deficiency. You can get it in non-vegetarians who take a good amount of meat as well. And we need to see why. There is a poor diet intake, there is malabsorption, and there are other causes as well. Now, under malabsorption, we have malabsorption problems occurring in the stomach and in the ileum. Now, let's talk a bit about how this B12 is absorbed. B12 is not produced by humans, unlike heme, so it needs to be taken from an external source. When we've taken B12, there's an R factor in the stomach that binds it, and then it's released. It's intrinsic factor that is released by the parietal cells of the stomach wall, goes and grabs a hold of this B12 and takes it down. It makes it resistant to all the acid that's there. It goes down all the way to the ileum, and that's where the intrinsic factor is released. Transcobalamin takes up B12 and it's transported to the tissues. So if there's anything along the way that is a problem, like even if there's a good acid medium is necessary for the intrinsic factor to be produced, and achlorhydria is associated with a low amount of intrinsic factor. There are other factors as well, which we will deal with. So in the stomach, the causes are gastrectomy, the partial or complete gastrectomy, achlorhydria, by giving proton pump inhibitors as well, and other forms of achlorhydria like a chronic gastritis. Intrinsic factor deficiency, which it could either be a congenital deficiency or it could be pernicious anemia in which there are antibodies made against the parietal cells causing intrinsic factor deficiency. Medicines like metformin also inhibit the absorption of B12 in the prevent the B12 from getting absorbed. Then you have ileal causes like tropical sprue, non-tropical sprue like celiac sprue, regional enteritis, and ileal resection. Fish tapeworm is associated with B12 deficiency, and there's blind loop syndrome. Blind loop syndrome is when there are little outpouchings in the intestine in which bacteria get collected, and patient usually presents with malabsorption syndromes and diarrhea. These kind of patients also you get B12 deficiency. Other causes of B12 deficiency include nitrous oxide, especially people who are anesthetists, who sit and work with nitrous oxide. There have been a few patients like that who've had nitrous oxide causing B12 deficiency and have had to have B12 injections all their life. Transcobalamin 2 deficiency. Folic acid deficiency is due to diet which is poor in folic acid, which is usually in alcoholics, in infancy as well. Malabsorption syndromes due to tropical sprue, non-tropical sprue, and drugs like phenytoin. It doesn't have any stomach factors. It mostly has intestinal factors. Drugs like phenytoin and phenobarbiturate also inhibits the absorption of folic acid. Other causes includes increased requirements like in pregnancy, in cancer. Any condition in which there is a high cell turnover can cause a folic acid deficiency, exfoliative skin diseases, and dialysis also. Then you have conditions in which there is increased reduction in the metabolism of the folic acid because it doesn't get metabolized. Dihydrofolic acid is supposed to get converted to tetrahydrofolic acid. That does not happen. And that would be because of inhibitors that you use like pentamidine, pyrimethamine, and trimethoprim, methotrexate as well.